And again, drug of choice for Pseudomonas is fluoroquinolone. Did you guys, have you had a lecture on hearing loss in children?
Yeah.
Okay, so hearing loss, some of it's going to be the same as in adults, but it's very common in children, and it can be life-altering in children because it will show up or present itself as delayed in speech or learning in children. So most of the causes are genetic. Let's see. So, and also hearing loss, congenital hearing loss is also syndrome. You know, certain syndromes have a higher risk of hearing losses, like Down syndrome children have a higher risk of congenital hearing loss. Other things that can happen while they're in either during birth or after birth, if kids are giving a certain type of antibiotic, do y'all remember which were ototoxic? Gentamicin is a big one that is ototoxic. But a lot of times, newborns are caught by newborn screening, right? You guys went over newborn screenings. Usually they're tested before they leave the hospital. They should be. Now, a lot of times people are now choosing to have babies with midwives. So as long as you have a patient, if they deliver, make sure they get their baby tested within, you know, a month, no longer than 3 months, to get their hearing tested. So we've already talked about conductive hearing loss, sensorineural, and then there's a mix, which is a combination of the two. These are severities of hearing loss: mild, moderate, severe, and profound. So mild, you can hear some speech, but soft sounds are hard to hear. You can hear some speech, but soft sounds are hard to hear. Like a whisper is very hard. Normal speech is easily heard for mild. It's a soft whispers and things like that, or soft speech, it's hard for them to hear. Moderate, you normally can't hear. That's when they start developing issues with hearing normal speech, like normal talking. It's difficult for them to hear that. And severe, usually those people can't hear any speech sound, and they can only hear some loud sounds. And then profound is no speech sounds, and then they can only hear very loud sounds. So what would you notice in a baby? Because babies can't talk, right? So you don't know that they can't hear. So a lot of times what you do is, of course I read that my child was having hearing issues because she was given gentamicin. But, so they don't startle. So if you notice a baby that doesn't startle, or you call their name and they don't turn, or you make a noise, you drop something, they don't turn to it, but they'll turn to you when you move. You know, they'll follow you because they're looking at you. But most babies, you can only tell is if they don't turn to loud noises, dropping things, or, you know. Now there's some babies that can sleep through concerts, you know, but those are different. Those are just maybe your sleep soundly. But if they're awake and they don't turn to dropping something, you gotta think about, oh, maybe there's something wrong with their hearing. Okay? Seems to hear some sound, but not others. And then the big thing there is single words. So you guys talked about milestones yesterday, right, for babies? So usually by the time they're 1, they should be having 1-word sentences, 2-word sentences. So if the baby's not making mama, dada, small sounds at an early, by the time they're 1, you need to think about doing a hearing check. And then in children, it's a little bit different, so they can talk by then. They can have some speech delay, or their speech is not clear. They do a lot of mumbling and jumbling. You're like, what did you say? You know, they talk really fast, or you think they're talking fast. They can't. So a lot of times it's like, do they have hearing loss, or would you be concerned something about like autism, you know, if their speech is delayed? But you can help kind of roll that out by getting a hearing test. My nephew, at first I thought it's because he grew up in a bilingual home. You know, his speech was kind of mumbled, or it just wasn't clear, and he ended up getting this And he didn't talk a lot, but he finally got tubes in his ears, and then he just kind of blossomed and turned into a totally different kid. Because they can't hear, they can't repeat what you're saying if they can't hear it. So that's a big thing to look for. Does not follow directions, unfortunately, that could be any kid. Often says, huh? And then turns up the volume on devices too high. So my friend's kid had a cleft palate. So she had structural abnormalities. She had tubes in her ears. And so when she would stay with me, I knew that it was time to either get her ears checked again or she might need a second set of tubes. Is her pad would be really high. It would be so loud. And I'm like, turn it down. And she could barely turn it down. And then she couldn't hear it. And it's still really loud. So that's something to think about. If your kid's jacking up the volume and then you tell them to turn it down and they still can't hear it when it's just still really loud, then I would think about something's wrong with their hearing. Okay. So again, already newborns later than a month. Other babies, so with my child having been on gentamicin, she had to have a repeat screening in about a year and a half, but no longer than 2 to 2.5 years, because that's when you start worrying about speech delay, learning issues, things like that. And then all children who do not pass a standard hearing screening test must have a full audiogram evaluation. So they do a newborn screening, but then you'll need to take them to an ENT or an audiologist to have a true full screening. So I was like, my kid was 1. I was like, how is she going to be able to say anything? So it's the same thing. They put little things on their little headsets that make noises. So they watch to see if they turn. You know, they change the decibels, and they make them turn their head, or they drop something, or if they see something clapping, but the noise is over here. It's kind of things like that they do for babies. Sometimes they put them to sleep to do a hearing test too. So treatment intervention, again, there's no single really treatment. It depends on the family. If they're not speaking, it could be speech delay. You might want to teach your kid sign language. That's always a big thing. Make sure they get seen by an audiologist, ENT, rule out other structural issues why they can't hear. A lot of times support groups for hearing impaired children. I always love those videos. You ever see those on Facebook, the kids that hear for the first time when they get a cochlear implant, or even an adult, you hear it for the first time. It's really amazing. Here's a question I always ask, I like to ask. Which would you rather have? If you're like your age now, would you rather have a loss of vision or a loss of hearing?
Hearing.
Really? Yeah. You wouldn't hear music? Nothing like that?
No, but see, they have those cool, like, people at concert now who, like, they rock out and they not only like do the words, but they'll do it to like the beat and all that.
I know, but you know, wouldn't that, well,
but you can still feel the vibration and stuff.
It's better than constant. I want my hearing.
Yeah.
I want my hearing. Oh, I was thinking about this.
Android sounds. Get my hearing.
That's what audiobooks are for.
Nose. Oh my God, I love this picture. I know who this little girl is. I love it. She actually looks like my friend's kid, so I need to send this picture to her because she looks exactly like her. So, did y'all have rhinitis already? Did they talk about it yesterday? Pediatrics. So again, rhinitis, allergies, runny nose. You're gonna get a lot of that. My kid's got a runny nose. It's yellow. It's I think she's got a sinus infection. Majority of the time, history. They live in a smoking environment. Their parents have allergies. Those are things you're going to ask about to differentiate whether or not it's just a virus or if they have allergies. Most of these kids will have runny nose. Their eyes will be itchy, watery. They may have a cough from drainage, things like that. So acute viral rhinitis is basically a common cold. So acute viral rhinitis, what kind of symptoms would they have? I think I already said it, but asymptomatic.
I have Ace's face.
So cold, common cold, what kind of symptoms would they usually present with? Cough. Generally, would they have fever? Not necessarily. Plus or minus, might be a low-grade fever. Risk factors. Cold winter months. Cold winter months, daycare, they're in school. traveling. And what's the most common virus for common cold? Huh? Rhinitis. Yeah. Good job. And generally, these are self-limiting, last 7 to 10 days. So again, counsel your patient, really the mother, the parents. Tell them they don't need antibiotics. That's gonna be the big thing. You know, if you tell them all the things they can do to help because their kid's fussy, you know, use this suction for babies, use this suction bulb to get the snot out. If they're a little older, you can give them some antihistamines, help stop that runny nose, humidifier, things like that, okay?
Can I ask you a quick question?
Yeah.
I remember hearing like preferences on cold versus warm humidifiers. What's your preference on that?
For me, it depends. So if they have congestion, well, I always told my patient to use a cool mist humidifier because it's usually the winter months because they get nasal dryness and they get nosebleeds. I feel like warm humidification helps more in the shower if you have a lot of nasal congestion. That will help it. I think it's either way, but I used to always tell my patients cool mist humidifiers. So, allergic rhinitis. Ace apart. Anyone?
Oh, yeah, that's me.
So what kind of symptoms would these people show up with?
Runny nose, congestion, drainage on the back of your throat. You can have a itching, you can have a cough because of the drainage.
What would you see on physical exam?
What's that sign? That one?
What is it called?
Salute.
Yes.
Allergic salute.
Yeah. You can have the allergic shiner. Risk factor is living in Oklahoma with allergies.
Yeah. Or again, parents. If your parents have allergies, most likely they may have allergies.
Diagnostic workup. I mean, you can do a smear to see if they're like eosinophils, like in the snot.
Yeah.
Right? Because
What type of hypersensitivity is this one? Do y'all remember?
IgE.
IgE.
That's one.
Type 1 hypersensitivity.
The treatment would be oral antihistamines, if they're old enough, it could be nasal.
What were their turbinates look like?
They're pale.
You want to answer it? Come on, answer it.
Pale and
Pale body. That's right. Okay. And then this is non-allergic rhinitis with eosinophilia. So these patients are going to be IgE negative. Right, they're going to have symptoms all year round. Usually allergic rhinitis is going to be when in the fall and in the spring. These people tend to have symptoms all year round. You can do allergy testing, most likely it's going to be, sometimes you have negative, but it doesn't mean that they're not having the symptoms. You know, because I have sent these people for testing, they're like, I have all these symptoms and I'm not allergic to even like 1 or 2 things, but they have severe symptoms. These patients, you would give them nasal steroids. You can start them on Singular if they don't do well on just an antihistamine. Singular is a good adjunct to that. And then, do y'all remember the asthma, aspirin, allergic rhinitis triad? This is what, right, the nasal polyps. This is the one that's associated with it. This is the rhinitis that is associated with it. So you can treat them with steroids. And so back in the days, we used to always just say sinusitis, but the new term now is rhinosinusitis because you generally don't have rhinitis without sinusitis. And without sinusitis, you don't really have rhinitis. So they kind of combine it together and call it rhinosinusitis. Acute, usually less than 4 weeks. Recurrent, could be 4 to 12 weeks, and then chronic, anything greater than 12 weeks. And then recurrent is more than 4 episodes within a 12-month period. So with those patients, they have the acute rhinitis lasts about 10 days. They get better. Recurrent, they have episodes where they'll be months that they're symptom-free. Then they'll have these episodes resolved with antibiotics. Then they get better. Then they have it again. So they always have symptomatic relief between episodes. And then chronic rhinosinusitis, they have it all year round, all the time. Those are the hardest people to treat, is the chronic rhinosinusitis. You could generally treat them with surgery. Oh, wait, sorry. So these are just major and minor risk factors. And then how do you diagnose someone with rhinosinusitis? Usually it's 2 major factors or 1 major and 2 minor. So go back to that list. So remember, a lot of times people will just say they have pain in their sinuses, but they also have to have other things like purulent drainage, they have a fever. So it can't be just that they have pain there. Because you can just have something viral there too, and just have pressure and pain, but not really considered a sinusitis. And a lot of times, you know, you want to ask questions, what does the drainage look like? Is it clear in color? To help you differentiate between bacterial rhinosinusitis versus viral. And then patients, usually you don't do a CT scan unless you send them to an ENT. Because an ENT will always have to have a CAT scan before they determine if they're going to do any surgery on them, to see if they truly have a chronic sinusitis. Because a lot of people will have these symptoms and it's just chronic allergies. They don't actually have sinus infections. So you'll do it and you'll take a CAT scan and be completely clear. And the patient still don't want to believe you. Like, look, there's nothing blocking your sinuses. We don't want to cut open your sinuses for nothing. It's your allergies. We need to be better controlled with your allergies. And then we send them to an allergist. Acute rhinosinusitis is purulent rhinorrhea lasting no more than 10 days. So generally, again, majority of colds are viral. So I usually tell patients, if they come and call me on day 2, and they want to be seen and have antibiotics, come back about 10 days later, you're still having the same symptoms, purulent drainage, then I will consider putting you on antibiotics. Queen of Spades. Again?
Oh, no, yeah, this is a spade, right? The shovel is a spade?
Yeah. Yes, never mind, it's the Queen of Clubs.
That's me.
Who said that? What? Ah. What's a common bacteria for acute rhinosinusitis?
I have no idea.
What is it for ear infections? I want to see in your memory these 3.
Strep pyogenes,
Strep pneumo,
the influenza, and the
well, med students, what do they have to take to get into med school?
oh, MCAT.
Yeah.
Okay, but
Same one. So, treatment. Diagnostic workup is basically you look in their nose, get a history.
supportive.
But if it's due to strep pneumo,
Antibiotics. Like amoxicillin.
and if there's resistance, you give them, you know, what is clavulanic acid, what group is that considered? Or augmentin, what class of drugs is that? Beta-lactamase. Then you also, remember with sinusitis, make sure you tell them to take guaifenesin. Thin out that mucus, get it out of their nose. Humidification, rinses, nasal rinses are good ones to do. Decongestants. So mild versus moderate disease, whether or not you want to treat them. Again, you can give them 48 hours, see how they do. If they're not any better, call you and you can start them on antibiotics. Recurrent, same thing. They have the same symptoms, has a break. These patients, again, will get better with antibiotics. Again, you want to look about why do they keep getting these sinus infections. Look at their, get them scoped, look at their adenoids. Refer them to ENT, they can have adenoidectomy. And that will usually help that in children. That's why a lot of kids get adenoids taken out or tonsils taken out when they're little, because they keep getting recurrent infections. Chronic rhinosinusitis that we talked about, low-grade symptoms, more than 12 weeks. Again, these people, if they are not doing well with treatment, send them to an ENT. They can have sinus surgery, or they may get allergy testing, things like that. Again, used to you could give empiric treatment, give them 3 to 6 weeks of antibiotics, but then you develop resistance again with those. Topical nasal steroids, nasal irrigation, and then again, surgery only when they're refractory to standard treatment. Again, complications of chronic rhinitis sinusitis would be orthocellulitis, meningitis. You can just travel. Osteomyelitis. Did you already have, do you remember? Yeah.
I have a question real quick. You may have said it, but with the treatment, you said with acute you would do augmentin.
Or amoxicillin, usually amoxicillin first. I usually like to give my patients amoxicillin, like a high dose, if they're an adult, like 875, or with a child, I would give her high dose amoxicillin first.
Okay.
Just because the clavulanic acid is what gives them diarrhea and GI upset.
Okay, so then if you move on and you have recurrent and you move to chronic, then are you still treating these each time they present with that same antibiotic, or are you, like at what point do you stop giving antibiotics over and over?
Right, well, so the people who have chronic rhinosinusitis can have an acute exacerbation on top of it. So if they're trucking along and they are always congested, always have drainage, then all of a sudden they get worse. They get a fever, their drainage gets really purulent, then I would treat them then. But again, if it's within 3 months, you wouldn't want to treat them with the same antibiotic. Or if you can do a culture, but most likely you have to send them to an ENT to get cultured. I would say if they're having symptoms like 4 times in 1 year, I would send them off to an ENT. Or if they're getting even closer together, I would go ahead and send them off to an ENT.
Okay.
Because it may be either that it's not treating, the bug is resistant to whatever you're giving them. So you try them off with amoxicillin first. They're still not better, put them on augmentin. And if it doesn't cover it, then maybe you would move to something like Cipro or erythromycin, something like that.
Okay.
And then if you've done 3 or 4 rounds of antibiotics and it's still not better, I would send them to an ENT. Yes.
Okay.
Are those the best alternatives if they're panallergic?
Panallergic, yes. So you can do Bactrim, but again, what you worry about with Bactrim is what's the big reaction you get with Bactrim?
Stephen Johnson.
So a lot of times I would give my patients clindamycin. But what would you get with clindamycin? Huh? So it's kind of a toss, you just do them erythromycin, but a lot of times we would use Bactrim. Bactrim or Clinda. Nosebleeds. Does anybody watch ER still?
I'm watching it right now. Ruin it for her. She goes, I'm always watching it, right?
So there was an episode last week, I'm going to ruin it for you. Just, sorry.
What season?
Well, the current season.
Wait,
what? Now. I'm starting, did I say ER?
Grey's
Grey's. I'm sorry, Grey's. Grey's. I'm sorry, Grey's.
Sounds like we're talking about Grace.
Last week's episode.
Oh my gosh.
So I hate to ruin it for everyone who's watching Grey's, but I'm going to tell you now. So this guy presents to the ER, and he's got a bloody nose, right? With a towel over his nose. The resident just sits him down and leaves him there. Says, oh, something about a roof night, blah, blah, I understand, blah, blah. Goes on his day. Later on, this guy is sitting there 5 hours in the ER. And then all of a sudden, now he's like spitting up blood. So he had a posterior bleed.
I thought posterior bleeds in a moment to have your nose.
Huh?
I thought posterior bleeds commonly get out of your after you're swallowed.
Well, he was.
He was. You lean forward, you think about it, if it's there, you lean forward. Because most times, what do most people who don't work in medicine do? They lean forward. They lean back, or they lean forward. I mean, it'll drip everywhere. But yes, most of it's draining from the back of the mouth.
That was the thing, it didn't look like he was bleeding that much, but he was like.
Because when you have a nosebleed, bad enough to go to the ER, it needs to be treated immediately. You can't just leave it be, even if it's from the front. Because there's been many times I've seen patients I saw them like the next day after they've been in the ER or whatever with nasal packing, or 3 days later to remove their packing. But it was because they had an anterior bleed, not a posterior bleed. But any nosebleed that presents to the ER, you guys need to take seriously.
Oh, and wasn't he like, any nosebleed that comes to the ER isn't just a nosebleed?
Right. Because, right, they don't come to the ER for nothing, you know? King of Diamonds. He's also the guy who lit that patient on fire. Who's King of Diamonds? Jenna. What's the most common place for an anterior nosebleed? What's that? What's it called? The conglomeration of vessels on the septum. What's it called? Kesselbeck's. Tonsillitis. I don't know. However you say it. Okay. Kesselbeck. Okay. K-I-E-S-S-E-L-B-A-C-H. Kesselbeck. My cough. Queen of Hearts. K-I-E-S-S-E-L-B-A-C-H. Who's Queen of Hearts?
I am.
What vessel is a posterior nosebleed?
No,
Let me give you the initials.
sure.
SPA. Think about the anatomy.
So septo, posterior superior alveolar.
Can I phone a friend?
You can phone a friend.
Do you know what it was?
Super posterior.
Yeah, I like PSA.
Palatine artery.
Oh, I'm sorry.
Or the anterior posterior ethmoid arteries as well, but most likely it's the sphenopalatine. Ethmoid arteries, anterior posterior ethmoid arteries, but it's most likely it's the SPA. So in children, majority of the time is they pick their nose. And you have to tell your parents that your kid is picking their nose. It occurs a lot of times in the wintertime when the air is dry. My child has this problem. She says she doesn't pick her nose, but she actually she has allergies as well, so she rubs like that at night. And the air is really dry, so we have to turn the humidifier on. She's had a nosebleed every night for 3 nights now. But I'm almost tempted to take her to my friend who works in Pediatric EENT and getting it cauterized, because she's got to have some vessel in there that needs to be cauterized. So that's how you treat it. Sorry. Physical exam, look in their nose. You'll have nasal speculums, which most offices may not have, but you can also use the tip as well. And again, be very cautious when you're looking at the septum, because you don't want to push it against the septum. It's very painful, but you look for any active bleeding areas. And you can cauterize it with a silver nitrate stick. This is just a picture of putting packing in there if it's a severe bleed, how you do that. And I've seen patients many times from the ER, they come in 3 days later, they've got a rhino rocket in their nose, and I have to remove it and cross my fingers that it doesn't continue to bleed. Or what I'll do is I usually will spray them with Afrin. So if you have a kid at home that has bloody nose, spray it with Afrin, phenylephrine, and nasal saline rinses. Always have your kid spray saline in their nose to keep it moist. Again, pull in this humidifier. Is that prevention? Yes, prevention, I'm sorry, yeah. But also to treat it too afterwards, after they've had a bleed. But now, if you're an adult who has a bleed, you want to make sure that they don't touch their nose, manipulate their nose for at least a week, try to. And then if they're on anticoagulants like warfarin or aspirin, they need to stop that if it's medically okay for them to stop it for at least a week. Posterior packing, that's just a picture there. It's a balloon. You put it in their nose, blow it up, pull it out, just kind of blocks that bleed. Now luckily, knock on wood, I've never had to take out anything for a posterior bleed. Most times they're managed in the hospital, and they should not be bleeding before they go home. Or they could die, like that guy. He died. Oh my God, I love that cat. I don't like cats. I saw that picture, I was like, oh my God. It's like a little. Because you're gonna get that. People come in, most common complaint, sore throat. What are they worried about? Strep. Especially if they're in school or in a daycare, they can't come back to school, they don't have a fever, or if they have strep. So a lot of times, we kind of went over tonsil hypertrophy when we're in ENT, but you'll see a lot of these in kids. So they have big tonsils. They would have obstructive symptoms, right? Our pediatric ENTs, they would always, the parents would call in and say, my kid snores. They would record the snoring, bring it in, let them listen to it, and they can have surgery. But they also have adenoid hypertrophy too. So when you're young, your adenoids are bigger. As you get older, they start to atrophy. And they're usually gone by the time you're an adult. But sometimes when I've scoped patients, and actually when they scoped me, I actually had some adenoid tissue still left over. But it's very thin, it doesn't block anything. But again, signs and symptoms of tonsillar hypertrophy is they have obstructed sleep in kids. Usually that's a big thing that their parents will say. They snore, they don't sleep well, they wake up a lot at night, they're not doing well in school. Because think about it, if you don't sleep, well, I'm sure you guys know about sleep deprivation. You don't do well in school, and their personality is just grumpy all the time. So you send them off to go see an ENT. They can do a sleep study, but most times they will scope them, look at their tonsils. Sleep study will help them determine, yes, you should probably have this tonsillectomy and or an adenoidectomy at the same time. Most of the times it's curative in pediatrics. They do well. Their symptoms usually go away. Adults sometimes it's a little not quite so. We tell them sometimes you may have a UPP, you may still snore, you may still have obstructive symptoms, you may still have to wear a CPAP. But with children, usually it's a little bit more curative. Yeah.
In your experience, do these kiddos who have those big tonsils tend to get more infections more frequently?
Yes. So we kind of go into that here when we talk about tonsillitis. But again, this is that same picture of the grading of tonsils. Look at those big nuggets. So those, I mean, can you imagine? So I would have teenagers or young adults show up in my clinic with tonsils that look like that. And when you get tonsillitis, whether it's infectious or not, they swell up and then they feel like they can't breathe. You can see why they couldn't breathe or why someone snores with tonsils that big. And I was like, when I'd see them, I'm like, you are 20 and you've been breathing like this all your life? And they're like, yeah, my parents, said I should have had a tonsillectomy as a kid, but my mom didn't want me to go through blah, blah, blah. But as a kid, it's much more tolerable and they recover easier than having a tonsillectomy as an adult. I think we talked about that before. So adenoid hypertrophy, same thing. It's lymphoid tissue in the posterior pharyngeal wall. It gets thick, blocks things. You get, otitis media, chronic irritation to that adenoid. You have chronic sore throat. Blocks the airway. And again, kids continue to have recurrent symptoms, send them to an ENT, evaluated for a possible adenoidectomy. See that? So the top picture, A, that's like a scope down. That's the posterior pharyngeal wall. And over there to the left, that's the opening to the eustachian tube. So you can kind of see when that gets really big, pushes it, blocks it, or you get a lot of drainage, and that adenoid tissue there is there to block it. The bottom one's a really big one, the bottom C. Look how fat that thickened that tissue is. So it pushes up against the opening to the eustachian tube and closes it shut.
Will that tissue grow back if they remove it?
Sometimes they do. Like when you scope someone who has had an adenoidectomy, in the middle of it, they almost have like an X, like a scarring. But then you see all this other tissue around it. So I think just like when they do a thyroidectomy, you leave a little bit of tissue behind. So lymphoid tissue, if that's still there, I would think that it still can get inflamed and may not grow, but it just gets bigger and inflamed. So I don't know that it grows new tissue. It's just a little algorithm for snoring. Because you'll get that a lot. You'll have if you work in pediatrics or family practice, you'll have a lot of children come in, their parents complain that they're snoring. already talked about tonsillitis. Viral tonsillitis, a lot of kids come in complaining of sore throat. What are some viral illnesses you need to be aware of for spades? Anybody? You? Okay. What's one viral, something that can cause a sore throat that's a virus that you think that's not? Yeah, but other things that it could be. Give me some differentials of just a sore throat, a viral sore throat. Mono. Did you do mono? Yeah, yeah, mono. And what bacteria, what virus causes mono? ABV. Okay. Can you name another one? Vesicles. Let's say a kid comes in, they got blisters on their hands, their mouth, and it's caused by. And I don't know if you guys talked about, did you hear about Peritonsillar? And what virus causes that?
HSV.
Coxsackie. Oh, enteritis is what causes hand, foot, mouth. Who said?
No, it's not.
Oh, yeah.
So you
There's several of them.
So you
Right. And you just treat them symptomatically, right? Make sure they're on a Tylenol, ibuprofen. You can tell them to use chloroseptic spray for the back of the throat. Salt water rinses, those are always good for sore throats. Warm tea, hot tea, something like that, just to help coat the back of their throat. This again, just a nice little algorithm for pharyngitis. So pharyngitis, tonsillitis is kind of used intermingle, however you say it, changeable. But, so a lot of times they'll say pharyngeal tonsillitis or tonsillar pharyngeal. So I just use tonsillitis usually. I'm getting my cards mixed up. Pointed items. What's the most common bacteria that causes bacterial tonsillitis? Strep pyogenes, right. Group A, beta hemolytic strep, however you want to say it. And will these people have lymph node swelling?
Yes.
They have fever?
Yeah.
Risk factors, again, being around sick, somebody's sick, you've had a URI, you can get tonsillitis, turns into a bacterial infection, a viral can turn into a bacterial infection. Again, eustachian tube dysfunction, allergies. Now, diagnostic workup, what should you do? Swab. So rapid strep. You can also culture it. And then, when to consider tonsillectomy. Did I talk about this when we were in ENT? Does anybody remember how many infections should they have in 1 year? 7. 7 in the previous year, 5 in the previous 2 years, or 3 for the past 3 years. 3 in each year. 7 and 1, 5 and 2, 5 and 5, and then 3, 3, 3. So those patients, you should send them to an ENT. And these need to be documented. So when you're seeing patients over and over for the complaint of sore throat, because they're going to come in complaining of sore throat every other month, it seems like. But you need to document, so it's 7 documented strep positive, not just pharyngitis, but strep positive. These are drugs, so you treat them with PenVK, amoxicillin, augmentin, any of those above. So they can show up like the one on the left. Sometimes they may just have a little petechiae. And some of them can really real bad, like the bottom one. The one on the bottom almost looks like it could be diphtheria. Because the diphtheria tonsillitis, they'll have like this grayish patch on the back of their throat. Petechiae on the palate. Chronic tonsillitis. These people have large, big tonsils, and they're very cryptic. They just get inflammation, not necessarily. Sometimes they get pockets of debris and bacteria that collect there. They develop tonsil stones. You can extrude these. They can do it themselves. I would gag. I don't think I could do it. But these patients, you'll treat them, and they'll say, "Oh, I was doing really good while I'm on the antibiotics," and the minute they stop them, they start having symptoms again: pain, swelling, can't, eat very well. Those patients, you should send them to an ENT because it's when they're older, like someone your age. If they miss school, miss work, those are other reasons why they should have a tonsillectomy, even if they don't meet that Paradise criteria. Is if they're missing work, how often they're having this tonsillitis, do they have sleep apnea? Those are other reasons that you can have your tonsils taken out. And those should be documented. So those are history things that you want to ask them. Anybody have tonsil stones? Can you extrude them yourself when you pop them out? So I tell patients who have these, and they just may have big tonsils and they have the stones. What they come in complaining of is that they have bad breath. They have chronic bad breath. So what I tell my patients is to gargle with warm salt water after every meal. They can also use a toothpick, like the water picks, and try to do that, or you can extrude it with a Q-tip. You can actually push them out. I love doing that when the patients will allow me to. Like, I could never do it because I gag just seeing that come towards my face. But most people, it's amazing how some people just open wide and you can just push it all out. So peritonsillar, cellulitis, abscess. These are kind of emergencies, or they need to be treated. These will usually present in the ER. And usually this is from either untreated or partially treated strep infections. Candidiasis. Oh. What's the most common cause of peritonsillar cellulitis or abscess?
Strep pyogenes?
Yes.
Mm-hmm.
Because don't forget, it's from either partially treated or untreated strep pyogenes. These people will have high fever. They'll have a severe sore throat. Okay. And these people, they'll have unilateral tonsillar swelling, and it pushes the uvula. Remember that? So you have deviation of the uvula, and their palate pushes it down. Everything looks weird when you look in their mouth. They may have trismus. They can't open their mouth because it's so swollen back there. Related common pathogen, diagnostic workup, physical exam, basically, you're going to look at them. I think this one. So, how do you determine the difference between a cellulitis and an abscess? If you give them antibiotics, the redness and the inflammation may go down with the cellulitis, and they still have a big pocket. So usually those are, then you know it's an abscess. And those abscesses need to be drained. Usually you stick a needle into it and extrude it out. I think it's usually an 18-page needle.
How do you keep the patient from swallowing?
The pus?
Yeah.
Do you do it?
Well, it's a needle with a syringe, so you can.
Oh, you don't just pop it in there.
Okay, don't pop it. You stick it in there and you drain it out. I know, I couldn't do it. You'd have to put me to sleep. See, look at it, pushes all the way over. And it's also called it's called Quincy also as well, or Quincy. I don't know how you say it. But luckily, again, I never saw any of these. My classmate from PA school actually she had 2 peritonsillar abscesses. She had to go to the ER both times, had it drained, and then she ended up having to have a tonsillectomy. So if you have someone who has more than one or recurrent peritonsillar abscesses, they need their tonsils taken out. And then you can have, from this, you can also develop retropharyngeal abscesses, so it drains down into the lymph nodes of the neck. They'll have high fever, sometimes some shortness of breath, drooling, they'll be dyspneic, and they'll have neck hyperextension. For clubs. Anyone? Nobody? No one's claiming to be? Ready to tell us, does anyone else have a joker, a black joker? Who? Kristen? So what's the most common pathogen you think for retropharyngeal abscesses? Huh? Strep. Group A, straight hemolytic, strep. You can also have staph. Usually these occur in patients who are 2 years old and younger. And if you do a neck film, you'll see some thickening of the prevertebral soft tissue and air fluid levels. And the air fluid level means there's an abscess there. But a lot of times what would be more helpful is CT neck, but again, you're going to give your patient undue radiation. You get a little bit with x-rays, but not as much. Treat them, you need to admit these patients and start them on IV antibiotics. And then during the abscess. And then oral candidiasis, I'm sure you guys have had this ad nauseum. In children, it's usually due to C. albicans. These are usually in babies that either the yeast is on the nipple, on the mom. So a lot of times you're going to have to treat them. It's very common, so you'll see these babies come in with all this white stuff on their mouth. You wonder, is that milk or is it yeast? Sometimes it's a combination of the two. But you usually would not see this in older children. Usually breastfeeding babies that you'll see a lot of yeast. Unless they had antibiotics. So risk factors, again, in an older child, what would you think would be a risk factor? Antibiotics and what else? Huh? Inhalers, right. You can give them oral nystatin suspension. Sometimes babies, you take a Q-tip, coat the areas in their mouth. You could also do gentian violet with that as well. I would treat the bottle nipples, the mother's breast as well if they're breastfeeding. Any toys and pacifiers that they stick in their mouth, you want to make sure you treat those as well. You see, it's kind of hard to tell. Is that milk? Or is it yeast? But sometimes it's very subtle, like the one on the baby at the bottom. You know, you really, it's not as obvious as the top two baby. And then epiglottitis. This one is a definite emergency. Okay. Jack of diamonds. So if you got this kid, comes in, sore throat, not talking very much, is drooling, has stridor, and what position do you think he'd be sitting in? Tripoding. Okay. And you want to examine him. Would you examine him? No. What would you do?
Oh, you have to get the airway.
Right, so your big thing there is airway. So what you do with a child who has epiglottitis, do not ever do is glide them down. Or accept them. Okay? And then so you get a lateral film here. What's the classic sign on thumb sign? Very good. And then how do you treat these patients?
Secure the airway. Antibiotics.
Right, what would you generally see on, you wouldn't scope them, but if you saw it, what would their epiglottis look like?
Really swollen.
Cherry red. Cherry red. And what are the common pathogens?
You get a vaccine for it, which is why we don't see it anymore. So the H flu.
And?
I don't know. Strep pneumo.
Strep pneumo, I think. And so these patients, you would give them IV antibiotics, and then once you rescope them and the swelling's gone down, they don't look like they have any airway compromise, then you can actually send them home after 2 to 3 days of IV antibiotics and put them on oral antibiotics for probably another 7 to 10 days once they go home. See, did all of that come back to you when you were studying it? But you know, in pediatrics, you're going to see all of this all the time. Pediatrics and in family practice and adults. These are the big complaints. You're going to have ear pain, you're going to have sore throat, you're going to have a red eye, pink eye, runny nose, all of that. So it's kind of nice you had it at the beginning and then you also have it now at the end. So, any questions? And I forgot, I was going to hand out the candy when you don't got the right answer. So y'all can just eat it. Okay. Thanks, guys.
Write your cards back.
Yes, can I have my cards back?
Colleagues like
Yes.
Who works in admin, who come over to my outline.
Why is there a thumb on it?
May of 2020, and I I'm not sick. All of a sudden, it's like, but I said, well, it's pretty cool. Like, I'm not going to be mad about it.